Hello, my name is David Gardner, and I am a professor with the Department of Psychiatry and the College of Pharmacy with Dalhousie University. I'm a pharmacist by training, and I appreciate the opportunity by the Manitoba Association of Senior Centres, as well as the Canadian Deprescribing Network, to bring this presentation to you called Having Difficulty with Sleep, Safe Options for Insomnia. So I have three objectives today. I'm going to review with you the age-related changes in sleep. I'm going to help increase your awareness of the risks and benefits of various sleeping pills. And I'm going to introduce you to something called cognitive behavioral therapy for insomnia, as well as how to access it and where you might find tools to support your use of that approach to the management of insomnia. Just a quick note to say that I don't have any conflicts of interest with the pharmaceutical industry, with the pharmacy business. I do have some grants, and I will be talking about Sleepwell, and I was the developer of Sleepwell, so that will come up as we move along here today. So let's start off with looking at age-related changes in sleep. All right, so here's some data that is from one study, but there are a number of studies that have looked at this question of, is insomnia a problem with age? And here we can see that as you get older, the rate of having difficulty sleeping does increase. So about 1 in 4 seniors will state that at some point in the last year, they had a lot of trouble falling asleep or staying asleep. Now, does that mean that they have an insomnia problem? Well, it means they've had some difficulties with sleeping, but as you'll see, there are different diagnostic categories for insomnia. And the real issue is, did it affect you the next day? Were you distressed because of this difficulty with your sleep? Three things change as we get older that can impair our sleep or the benefits that we have with sleep. First is reduced sleep quantity and quality. And when we talk about the quality, we're really talking about a substantial decrease in what's called deep sleep. So some people talk about it as stage 3 sleep or deep sleep. When we're younger, for example, teenager, we get probably the maximum amount of deep sleep, but that quickly erodes as we move through the adult years. And when we're 70 years of age, we're down to about just 10% of the deep sleep we once had as a teenager. Sleep fragments as well. There may be a number of nighttime wakenings as well as naps during the day, making it seem like that sleep is something that we get in bits and pieces, which is not very satisfying any longer. We talk about sleep efficiency, meaning that you want to have as much of your time in bed being asleep, but many people find they're having difficulties getting to sleep, and then they wake up on several occasions, and then they have what we call early morning awakening, where they're lying in bed, going back to sleep on and off. So we talk about this issue of sleep fragmentation, reducing our overall sleep efficiency. And then the last one is a change in our circadian rhythm, where our nighttime, or evening time, I should say, release of melatonin from a part of our brain occurs a little bit earlier. And that can cause us to feel ready for sleep a little bit earlier in the evening. But the resulting effect is that we may be waking up early in the morning, even when it's still quite dark out. Some people, if they were regularly going to sleep at 10 or 11, might find as they get older that they have a difficult time staying up past 9:30, and then they wake up at 3:30 or 4 in the morning and really can't get back to sleep. So these are the main changes that occur with sleep. They, in and of themselves, do not necessarily mean that you have a sleep disorder. From a diagnostic perspective, insomnia is difficulty getting to sleep, staying asleep, or waking up too early and not being able to fall back to sleep. If you have insomnia and you have it for 3 nights or more per week, but less than 3 months, it's called short-term insomnia. And if you have it for more than 3 months, it's referred to as chronic insomnia, also known as insomnia disorder. Here, though, I think it's simply stated as what the experience of insomnia is. In the morning, you get out of bed and you're extremely tired because you had a poor night's sleep. By the afternoon, you're dying for a rest. And at night, you're back to the old problem. You just can't get to sleep. Causes insomnia. Well, the causes of insomnia are a very long list if you look at the individual causes. So I think it makes more sense to look at the category of causes. there are predisposing factors, precipitating factors, and perpetuating factors. So the predisposing factors are, when we look at genetics, maybe you come from a family of light sleepers, people who have chronically had difficulty with sleep. There are some personality traits that are associated with sleep problems. For example, sensitivity to anxiety symptoms or perfectionism, tendency to internalize problems. You really can't do an awful lot about the predisposing factors. Then there's the precipitating factors, and these are the factors that trigger the onset of insomnia. So we call those psychophysiological stressors. For example, a loss of a loved one, a loss of a job, something stressful at work, something stressful at school if you're younger. So personal loss in one way or another, or significant stress that you're feeling can interfere with your difficulty with sleeping. So that's one category of precipitating factors. Another category is physical health problems or mental health problems. So if somebody has panic disorder, for example, it's not uncommon for them to also have insomnia when a recurrence of the panic disorder comes. Or they may have physical pain associated with, for example, irritable bowel syndrome or some sort of inflammatory condition like rheumatoid arthritis. Medications, as I mentioned earlier, may be a cause and precipitate difficulties with sleeps, and the use of substances. As I'm sure you've been asked in the past, what is your use of caffeine? When do you use caffeine? Are you one of those people who say caffeine doesn't affect me, but I'm having difficulties with insomnia? Well, it could very well be that caffeine does affect you, and it might surprise you that caffeine stays in the system for many hours, interfering with the brain's capacity to relax and be ready for sleep in the evening. So even an afternoon cup of tea for somebody who has difficulty with insomnia is not necessarily a good idea, and probably should be moved to the morning and stay only in the morning. And then there's the final group of factors that cause insomnia, which we call perpetuating factors. And these, in my mind, are the most important factors when we talk about the management of chronic insomnia. So perpetuating factors are really the factors that transform an acute problem of insomnia, where insomnia has lasted a few days or potentially a few weeks, and then it has been moved into a chronic insomnia problem. For example, some people may have a behavioral response to the insomnia by lying in bed a little bit earlier, going to bed earlier because last night or the night before you had great difficulty sleeping, so you want to give yourself a better chance for falling asleep on the next night. And in fact, going to bed earlier and lying in bed and not sleeping can actually perpetuate the problem, because you start to associate your bed and your pillow with being frustrated. And you can see how that might actually build up this classical conditioning association between being in bed and not having a relaxed brain, but actually having a brain that is hyper aroused with frustration and anxiety about sleeping. And so it's really important to break that cycle by understanding how you've got to that point. And I'm going to be talking about cognitive behavioral therapy for insomnia, as that is really important for understanding what's caused the chronic insomnia and how to undo that association itself. All right, so let's start off by focusing on the sedatives themselves. So we have a long history of using sedatives. Going back millennia, the use of sedatives was really alcohol, opium, cannabis, and herbals. And if we think of cannabis, I think you would agree that we've kind of come full circle. Cannabis has come back, become quite accepted, and from my experience, cannabis is now one of the leading new, if you want to call it, medications out there for people who have chronic insomnia. So what is old is new again. If we move into, 150 years ago, medications were developed. Chloral hydrate and bromide salts were identified as being quite effective for managing sleep when initially used. But one of the problems was people quickly built up a tolerance to the medication and would need higher and higher doses for them to be effective. But unfortunately, higher doses were very toxic and associated with fatalities. Moving on to a little bit later, into the 20th century, the early part to the mid part of the 20th century, medications called the barbiturates became very popular, but they were very quickly identified as having the same issues of toxicity and overdose, as well as the development of a very severe dependence problem and severe withdrawal adverse effects when abruptly stopped. People also became quite used to the medications, appreciated the effects that they caused, and they were associated with drug abuse. In the 1960s, a class of medications called the Benzodiazepines really changed everything from the old medications and took over across the 60s, 70s, and 80s as the sleeping pills of choice. So what advantage did they offer? Well, the real advantage they offered was their safety in overdose. They were not nearly as toxic as the older medications, but unfortunately, they did lose their effectiveness over time relatively quickly, causing people to use higher doses. They did cause people to feel some euphoria when using them, and therefore they were associated with dependence and abuse. And when taken with other medications, they were not necessarily safe. So their safety was only when they were used alone, even if they were used in large doses. But if used with other medications or substances, alcohol, opioids, and the benzodiazepines, then there was a terrific risk of irreversible harm or possibly death. So we still really, with the change to the benzodiazepines, really still had an awful lot of concerns that we had had for a long period of time. In the 1990s, people moved away from the so-called benzodiazepines to the Z drugs. But it turns out the Z drugs work the same way as the benzodiazepines. From a molecular perspective, they look different than the benzodiazepines in terms of the drug's structure, the molecular structure. But how they work is the same. So I actually do not consider the Z drugs to be different from the benzodiazepines, and I refer to them as the BZRAs, the benzodiazepine receptor agonists, because they all do the same thing in the brain. They all act in the same way. So the concerns that we have with the benzodiazepines also apply to the Z drugs. And then when we move into the 2000s, in the last 1 to 2 decades, some older medications have sort of been brought back into the fray for being used as sedatives. For example, doxepin is an old antidepressant medication that has antihistamine effects. And when you take an antihistamine and it goes into your brain, it makes you tired. And so it's not really an advance. It's the use of an old medication and using one of its pharmacological effects to help you with sleep. We're also using melatonin more, but melatonin has not actually been shown to be effective in the management of a number of sleep problems. Even though our brain makes it, even though we see it as a natural remedy, it's not particularly effective. And it seems to be highly unpredictable who will have a benefit from it. So there may be a reason to try it, but I would say most people who have chronic insomnia tend not to find it to be a particularly effective treatment. So in recent years, there's been a tremendous focus away from sedatives, hypnotics, and other substances to non-pharmacologic, non-substance approaches in how we can get a good night's sleep. And I'll talk about those in a few minutes. So just to help you recognize some of the medications that some people are using and have been using for a very long period of time for helping them with sleep, there are names like Zopiclone. That would be Canada's #1 prescribed sleeping pill. And then the benzodiazepines like lorazepam, clonazepam, temazepam, oxazepam, and there are several others. Lorazepam is the #1 prescribed benzodiazepine used for sleep and for other reasons. Then there's other prescription medications. Trazodone, quetiapine is also being used for sleep. I feel quite uncomfortable about that because if it's for sleep only, it's an antipsychotic medication, and it has a number of pharmacological effects and risks. So I think it is a very useful medication when it's for people who have other mental health problems and also sleep problems. It seems to be a reasonable medication for that. But if it's only a sleep problem, then it wouldn't be my recommended treatment. And then there's the non-prescription medications and substances that I've already mentioned. So melatonin, antihistamines that you can buy over the counter at pharmacies, cannabis, natural remedies that there's a whole variety of them that people have used over the years. I've been interviewing a lot of people who are 65 and older of late, and many of them have said they've tried them and didn't find them particularly effective. And I've also talked to people about their use of different substances and medications, and a few of them have told me, well, I do use alcohol to get a good night's sleep. These are people who say alcohol helps them fall asleep, but then they do acknowledge that they're awake many times during the night. And that is a problem with alcohol, in that it can help bring on sleep, but then it can actually interfere with sleep so that you're waking up more often and feeling less well rested the next day. And then, of course, there is the hangover that many people experience if overindulging with alcohol. So here's a picture of sleeping pill use, particularly the benzodiazepine receptor agonists, so those benzodiazepines and Z drugs. And you'll see that the rates vary substantially when going across Canada. Where I'm from, here in Halifax, the rates are relatively high compared to Ontario and westward. So we seem to have a substantially higher rate of use of these sleeping pills in Atlantic Canada. If we look at Manitoba itself, Manitoba would stand out from Western Canada perspective as a higher use province in terms of the rate of benzodiazepine use in people 65 and older. And this is based on data that is indicated by receiving the same sleeping pill in one prescription during one quarter, and then the same sleeping pill in the second quarter of the year. And those two consecutive quarters were identified as indicating long-term or chronic use. So 15% of women and 9% of men, averaging out to be 13% of Manitobans using benzodiazepines and or Z drugs chronically, who are 65 and older. So let's talk about how effective sleeping pills are, and then we'll talk about their risks. So this picture shows you, when we compare from research the effect of the Z drugs, so the benzodiazepine-like Z drugs, how effective they are compared to placebo, taking a sugar pill, in terms of the time it takes you to fall asleep. And I think you'll be very shocked to find out that across all the different studies using Z drugs, the average time to fall asleep was only 7 minutes faster, according to the individuals who were in these studies, based on their estimates of how long it took them to fall asleep. And when we look at how long people actually slept throughout the night, there is only a 14-minute increase in total time sleeping, which again is an underwhelming number based on the amount of use of these medications. So now we have an idea of their effectiveness. Let's also look at their risks. So with the opioid crisis over the last 20 years or so, we have seen a substantial increase in the rate of death involving benzodiazepines when combined, especially with opioids. That rate itself has gone up 8 times over the last 20 years or so, which is indicating the concern of these medications when combined together. We know that since these medications have been used in the 1960s, they increase the risk for falling. So injurious falls have a higher rate of 60% when using these medications compared to not using these medications. Looking closer at the types of injuries, the risk for all types of fractures is increased 66%, and the risk of hip fractures specifically is increased between 52 to 90%, depending on which study you're looking at. One thing that's really not well known is the effect of benzodiazepines on our immune system. The benzodiazepines actually have an impairing effect on cellular immunity, so really the white blood cells that help us manage anything that could be leading to an infection. This study that I'm quoting here shows that when people are taking a benzodiazepine at the time they develop the flu, the influenza virus itself, their risk of developing pneumonia is increased 325% compared to those people who are not taking any benzodiazepines when they develop the flu. And more concerningly is the risk for death in relation to the complications of the flu itself. That risk is increased 240% to 2,000% if you're taking a benzodiazepine when you develop the flu compared to if you're not taking a benzodiazepine when you develop the flu or being infected by the influenza virus itself. So I should add, it's really important to think about, we don't know the effect of taking a benzodiazepine and developing the coronavirus infection, COVID-19. Those data have not yet come out, and so I cannot say if that virus also increases, if taking a benzodiazepine also increases your risk for the complications associated with COVID-19. Another factor that we know, but probably not as clearly as recent research has shown, is the effect of sleeping pills on driving. We know that sleeping pills impair driving, but what we didn't know until some studies were done in the Netherlands that showed people when they're driving the next day, 11 hours after taking Zopiclone, Canada's leading sleeping pill, that their driving impairment is at the same level as if they had a blood alcohol content of 0.08, which I'm sure you're aware is an illegal level of alcohol in your blood. Other concerns, again, that have been known for a long time is cognitive impairment associated with using benzodiazepines and Z drugs. So we've known about the fact that if you're taking one of these sleeping pills, it can be hard, if not impossible, to remember what happened the next day when you had taken your sleeping pill. If somebody said, oh, do you remember doing this last night or that last night? You have what we call retrograde amnesia. The benzodiazepines and Z drugs make it difficult for you to form your memories so that they're longer lasting memories. And that's what's really important that sleep does for us. So sleep really helps us consolidate our memories so that we are able to remember what happened to us yesterday. If we take a benzodiazepine because of a sleep problem, you would hope that it would actually improve our ability to remember things. But the sleeping pill itself actually impairs memory problems further. There are also some studies that associate sleeping pills with the development of dementia, for example, Alzheimer's disease. Is it a causal association or just a coincidence? That detail has not yet been worked out. But what we do know is that the higher the use of the sleeping pill, the higher the rate of dementia as we get older. Now, it may be that people who are going to develop dementia have a predisposition to have sleep problems before dementia starts. So that's what makes it difficult to know if it's the sleeping pill increasing the risk or the sleeping problem increasing the risk. And the last thing I want to mention on this slide is how sleeping pills can erode our confidence. If they can interfere with our cognitive abilities and they can interfere with our physical functioning, making our reflexes slow down, making it easier to stumble or fall or even just feel unsteady, we're less likely to socialize, we're less likely to physically exercise, we're less likely even to just leave the house. And so the use of these sleeping pills has actually been associated with an increased concern about falls, increased concern about our cognitive functioning because we're having more difficulties remembering things, and a decrease in socializing, thereby leading to social isolation and loneliness. And then there is this concern of dependence when taking sleeping pills. And the concern really is something that happens shortly after starting to take sleeping pills. You can develop physiological dependence within just 1 to 2 weeks of regularly using benzodiazepines and Z drugs to help you with sleep. And this becomes evident when you stop taking a sleeping pill that you've been taking for 2 weeks, for example. If you abruptly stop that sleeping pill, there's a really good chance that you will not have a good sleep the next night. And a lot of people will think, oh, I still have a sleeping problem, and don't realize that is a physiological or a pharmacological effect of the withdrawal of the sleeping pill. Your brain is getting used to the sleeping pill causing sedation, and then you take away that effect, and your brain doesn't get the sedative effect, and it goes through what we call a withdrawal effect. But it's the pharmacological withdrawal of the drug being removed from the brain and having a counter response of brain chemistry due to its absence. So I sometimes say one of the leading causes of sleeping problems in older adults where the population has a high rate of use of sleeping pills is the withdrawal of the sleeping pills, not necessarily because there is a higher rate of sleep problems, but because there's a higher rate of people stopping sleeping pills. And so why are they stopping sleeping pills? Well, all sorts of reasons. You forget to take it, you run out, your doctor says no more, the pharmacy tells you that the medication is on back order, you forgot to go to the pharmacy and you go to the cupboard at night and you see that you've taken your last sleeping pill the night before. You're tired of taking sleeping pills and you want to try a few nights without sleeping pills. There's lots of different reasons that people will go a night or several nights without sleeping pills and will experience a physiological or pharmacological withdrawal. The leading symptom of that withdrawal is insomnia. And this will make the individual believe that they still have a sleeping problem. And sometimes this will lead to a higher dosage, and that can even exacerbate that association of stopping the sleeping pill and going through a withdrawal syndrome. So it's really important to understand that the sleeping pills vicious cycle and the dependence associated with it is one of the leading causes of insomnia. And we can get around that by gradually reducing the sleeping pill dose as opposed to going cold turkey. All right, so with that segue, why don't we move on to talk about stopping sleeping pills? And as I go through this section, I do want to point out resources that are available from the Canadian Deprescribing Network, which I'll start off talking about, and then resources available from Sleepwell. And as I mentioned earlier, I developed Sleepwell along with some colleagues, and so I'll show off some of the resources, and hopefully you'll be able to take advantage of the Canadian Deprescribing Network's resources, as well as the mysleepwell.ca resources that are available for free for you to use. So the most important approach to stopping long-term use of sleeping pills is the GDR, or the gradual dose reduction approach. So when you look at this graph, I want you to take notice of a few things. On the x-axis, you'll see that it says weeks. So each week, the dosage decreases over time. But what's obvious is that it takes many weeks, and in this case, it was over 14 weeks to stop the long-term use of sleeping pills. For some people, it actually is twice as long as that, or 3 times as long as that, and for other people, it's half as long as that. It can take a highly variable period of time to stop sleeping pills, but we generally recommend that if you've been taking them for if you've been taking them for over 2 years on a regular basis, that you do not stop the sleeping pill faster than 6 weeks. And usually we say how quickly you should stop it is going to be somewhere between 6 weeks and a year. And it's highly variable depending on the individual and how sensitive they are when reducing the dose. Something else I want you to notice is during phase 1, you'll notice the steps going down are larger than phase 2 and phase 3. So in phase 2, the steps get smaller. And then in phase 3, instead of stepping down the dose every week, the dose is stepped down every second week to slow the gradual dose reduction schedule down. The most difficult part of stopping sleeping pills is the last part. And so it makes sense to slow things down and be more cautious closer to the end. Phase 4 is a reminder that when the medication is stopped, it's still a good idea for you to keep in touch with your healthcare providers. And I want to emphasize that pharmacists are really critical in the gradual dose reduction process. They can help you with identifying what dose to take along with your doctor, and you can keep in touch with them on a regular basis to let them know how you're doing with the gradual dose reduction. And this may be something that you find is a little bit easier to do than to see your doctor, as for many people, seeing your doctor on a regular basis can be quite difficult. But a pharmacist is always just a phone call or a quick visit to the pharmacy away. Now I'm going to introduce you to a resource that is potentially one of the most important and helpful resources that is free, available from the Canadian Deprescribing Network, and it's effective at helping people slowly reduce their use of sleeping pills, come off of sleeping pills, and not need sleeping pills in the future. So this is called the You May Be at Risk, or we also know it as the Empower brochure, because it truly does provide information to you, motivates you, and enables you or empowers you to reduce and stop and end the need for sleeping pills. So it identifies on the cover what sleeping pills it's referring to to help you identify if it's one that applies to you or to your loved one. It provides information that you can interact with. So you've got a quiz, you've got answers to the quiz, you've got other information that you can assess your knowledge with. Again, sort of a yes or no or true or false set of questions for you to test your own knowledge. And then a description of some alternative ways to get a good night's sleep. A story about Mrs. Robinson and her experience with sleeping pills and stopping sleeping pills. And then finally, a calendar, if you will, that provides clear guidance on an effective strategy for tapering off or a gradual dose reduction to finally stop the use of sleeping pills. So this brochure is recommended for individuals, but not alone. There is another resource that's called How to Get a Good Night's Sleep Without Medication. And you'll see that it's also available at the same resource, deprescribingnetwork.ca. And both of them are free, whether you want to print them on your own system or contact the Canadian Deprescribing Network and ask for copies to be sent to you. And this is something you can share with others if you're interested. And the reason I'm so excited about sharing that with you is because it was studied in a very well-designed study where people were provided this package of information in some places, and in other places they didn't get the package of information, and which places were selected was done by random selection. The group of locations and the individuals who received them, that lived in those locations that received these, were able to stop their use of sleeping pills over 6 months at a rate of 27%. And compare that to what we call treatment as usual, meaning you don't get these booklets. Only 4.5% were able to stop sleeping pills over the same period of time. So they truly did enable the individuals to stop using sleeping pills. And what was found is that the more those individuals interacted with their pharmacists and physicians with those booklets, the more likely they were to actually stop using sleeping pills. Moving on to resources available at mysleepwell.ca, we have something that is complementary to what you'll find at the Canadian Deprescribing Network. First is the Stop Sleeping Pills Guide, so you can review this one-page guide in terms of the advice. So there's 6 points of advice, and they generally cover things like make sure that it's gradual dose reduction, add cognitive behavioral therapy for insomnia to increase the probability of doing well, stopping your sleeping pills and improving your sleep simultaneously. Stay in contact with your healthcare provider on a regular basis. When you're reducing your dose, do it on a consistent basis. Make it Mondays, for example, if you want to reduce your dose in a consistent way. But be flexible. It doesn't always have to be as planned. There may be things that throw the plan off, so you may have to adjust the plan, which is fine. And the bottom one is a technical term for how long the medicine works in the body, the long T-half or half-life. And sometimes, when I started in my career, it was common for us to take people who were taking short-acting sleeping pills and move them over to a longer-acting sleeping pill. We don't do that anymore. And on the right, you'll see 2 pictures, one called stairs and one called slow slide. We really can take either approach, gradually reducing the dose, kind of like a staircase where the step down in dosage is the same for each step, or the slow slide where the step down in dosage gets smaller over time, as I was explaining previously. It's meant to be interactive, so you can add the name of your medication, how long you've been taking it, what your dosage is, and what you think might be a reasonable period of time for the dose reduction to occur. In that middle section that says, how long have you been taking the sleeping pills? The reason that's asked is to find out how long you should take to reduce the dose over time. And then there is the Stop Sleeping Pills Planner, which goes along with the Stop Sleeping Pills Guide. And it is meant to be filled out by your healthcare provider. And I actually recommend that a pharmacist do the filling out because they know the tablet strengths that are available, which pills can be cut, how to cut them, if they can be cut in half or in quarters, and so forth. So it may be that you have a discussion with your physician and then the pharmacist about the plan, and the pharmacist can make the plan very practical. If it's a very long taper, for example, this person is taking both lorazepam and zopiclone, then it may take several months to slowly stop the sleeping pills over time. So I recommend that you take about 8 weeks at a time and see how it goes. The first 3 columns are filled out by the healthcare provider, and then the last 2 columns are filled out by the person who is using the sleeping pills. And they indicate what actually happened. So after 8 weeks, you can revisit how things went along, and then you can plan the next several weeks, moving on with the taper going down. And that's another segue. Let's move over to talking about something other than sleeping pills. So a skill testing question that I'm hinting at here is, what is the first line recommended treatment for insomnia disorder or chronic insomnia? And just a reminder there, chronic insomnia is having sleep problems on 3 or more nights a week for at least 3 months. And the answer to that is cognitive behavioral therapy for insomnia. So the American College of Physicians in 2016 published a clinical practice guideline that recommended that all adult patients receive cognitive behavioral therapy for insomnia as the initial treatment for chronic insomnia disorder. Now that really does go against what has been happening for years and really decades for the management of insomnia. It has been sleeping pills that have been the first treatment for insomnia, whether it's acute insomnia or chronic insomnia. So this clear recommendation goes against what has been the standard of practice, and it's trying to change the overall approach of how insomnia is managed. The European Sleep Research Society came up with basically the exact same recommendation a year later, 2017. And if you want to take a note, it says in the second sentence, a pharmacologic intervention can be offered, sleeping pills, if CBT-i is not effective or not available. And so many people would say, well, CBT-i really has not been a viable option in the past for my patients. But this is no longer true, and this is why we developed Sleepwell. And I'll go into how people can access self-guided formats of CBT-i on their own. And I've been involved in the generation of guidelines recently where we also recommended the use of cognitive behavioral therapy for the management of chronic insomnia problems as a way to help people stop sleeping pills and as a way to avoid the need for sleeping pills. And I want to re-emphasize, and I've said it earlier, that what causes chronic insomnia are the perpetuating factors that we discussed earlier. Sleeping pills do not do anything to address the perpetuating factors that result in chronic insomnia. CBT-i directly addresses those perpetuating factors, hence the advantage of CBT-i over sleeping pills. So what is CBT-i? I've talked about it, I've said it a few different times. It is actually a 5-component approach where it's kind of like a menu of options, if you will, that you can learn about and then determine which ones fit with your needs and which ones you find to be most effective to solve your specific sleep problem. So the 5 components are identified in different ways depending on which resource you go to. If you go to Sleepwell, you'll see them identified as sleep drive, sometimes referred to as time in bed restriction therapy or sleep restriction therapy. Control, also referred to as stimulus control therapy. Thoughts, also referred to as cognitive therapy. Hygiene or sleep hygiene. And relaxation therapy, which we just refer to as relax. CBT-i is one of the best studied, best researched interventions for the management of insomnia. And that's why US guidelines, European guidelines, Canadian guidelines are all recommending CBT-i for the management of insomnia. And you can have other health concerns. You can have physical health concerns that cause sleep problems. You can have mental health concerns that result in sleep problems. Or you can have both physical and mental health conditions that are associated with sleep problems. There's a wide range of studies with a wide range of people, older, younger, people who have been taking sleeping pills for a long time or not taking sleeping pills at all, people who are going through menopause, have gone through menopause, people who are being treated for cancer or have been treated for cancer. The studies have looked at when you get CBT-i, do you get it from a therapist or do you get it from a book or some online course, or even using a phone app? There are a variety of different formats or platforms for which CBT-i has been found to be effective. So CBT-i itself is really a time-limited intervention for the management of chronic insomnia. Most people who do use CBT-i do it for about 6 weeks. Each program is a little bit different, but most of them are about 6 weeks in duration. So shown here is just an example of how a course can unfold for the individual. And just imagine that this course itself is in a book. So a self-guided book on how to improve your sleep. You start off with learning how to use a sleep diary, and you use a sleep diary for about a week, each morning logging how you slept the night before. And then after that 1 week, you start to learn about sleep hygiene and stimulus control mechanisms or strategies for improving your sleep. In about another week to 2 weeks later, you start to learn about sleep restriction therapy, or what's also known as time in bed therapy, which we refer to as sleep drive, because you're really working on improving your sleep drive through that approach. And then other techniques fall into place usually around the 4th week. For example, relaxation techniques and cognitive therapy itself. So here's a sleep diary. This sleep diary is available for you to print off if you're interested. And you can start to log your own sleep, and you can do it 1 week at a time with each individual page. We want you to note that there are 2 important numbers that you can get from your sleep diary itself. One is your total time asleep, or your sleep duration, and that's in the bottom right. And that's something that you calculate based on the time that you fall asleep to the time that you wake up. Subtract the times that you wake up in the middle of the night. So if you go to bed at 11 at night and you wake up at 7 in the morning, that's 8 hours. But if you're awake for 2 hours in between, that's only 6 hours of sleep. So you would record your total sleep duration. And then you also want to record your sleep efficiency. So let's say you're somebody who goes to bed at 11 o'clock at night, and you turn the lights off and you try to go to sleep immediately. And then when you wake up at 7 in the morning, when you wake up, you get out of bed, you don't lie in bed. Those are really good things for improving your sleep efficiency. But if you're awake for 2 hours in the middle of the night, you would have 75% sleep efficiency, because you're in bed for 8 hours, but you're asleep for 6 hours. If you were awake for 4 hours, you would have 50% sleep efficiency. And sleep efficiency is really important to calculate for when you're using sleep restriction therapy, because you start off with being in bed based on your sleep diary's recorded total sleep time. So it's one of the most effective components of CBT-i is time in bed therapy, also known as sleep restriction, or what we call sleep drive therapy. What you first do is you look at your total sleep time. And if your total sleep time is 6 hours, then you are to be only in bed for 6 hours. So if you look at the top right, you'll see there is a bedtime and a rise time. You set your rise time based on the time that you would like to get up. So if you say, I like to get up at 6:30 each morning. And if you look back over the last week or two, and you've noticed that on average, you're asleep for 6 hours, and you're feeling like your insomnia is very bothersome, a good approach is to use this time in bed restriction therapy by starting off with just being in bed for 6 hours. So your bedtime would be 12:30, and your rise time would be 6:30. And if it was that you were going to bed at 11 o'clock, you wouldn't be allowed to do that. You would be going to bed at 12:30. And that helps to consolidate your sleep. That helps to erase being in bed and frustrated at the same time, and helps you to establish a new, more positive relationship where that the time you go to bed is the time that you're so tired you will immediately fall asleep, as opposed to have racing thoughts, difficulty falling asleep, and being frustrated about falling asleep. So where can you learn more about this? Because clearly My talking to you about different techniques of falling asleep is not actually going to help you learn these techniques. So Sleepwell was developed for that specific reason, to provide you with clear, practical recommendations of how to access CBT-i in a way that suits your needs. So there are different recommended books that are all self-guided CBT-i books. So when you go to the Sleepwell website, you'll see these books recommended. So we have a few of them identified here. Sink into Sleep was just published in November in its second edition. So the first edition, I think, was 2012, something like that. And the second edition now just came out by a Canadian psychologist from Queen's University. A very straightforward guide, one that I would recommend if you're considering using a self-help approach to managing sleep problems. That would be a good book to become familiar with. There is the Cleveland Clinic app called Go to Sleep. So if you prefer an app to help you with CBT-i, this one is a relatively affordable app. There are some other apps, but they're much more expensive. And then there are other approaches. Something relatively new in Canada is called Haleo. And this actually gives you direct access to a therapist who is a specialist in cognitive behavioral therapy for insomnia. So if you have an insurance policy, it may actually cover the cost of Haleo. But otherwise, it's $100 per session, and they recommend completing 5 sessions. So for an individual, it might be cost prohibitive. So here's what you'll see on the website when you go to My Sleepwell. Information about insomnia, sleeping pills, CBT-i, and Sleepwell recommends. So just to look at what you'll learn about CBT-i, what is CBT-i, how to get started with CBT-i, what to do once you've selected an app or a book or some other approach to learning about CBT-i, and then other information. What we have on Sleepwell are supports for what you choose. So if you choose a book, you may go to our website and click on any of the icons you see there: control, sleep drive, relax, thoughts, and hygiene. And you will be provided with different tools or more background information that help you use these different techniques. And when you look at the information about sleeping pills, there's a quiz for you to go through to learn information to learn about some of the adverse effects or dangers, the information I showed you about the vicious cycle, and then the tools that I have introduced you to in terms of how to stop sleeping pills, and some background history as well about the sleeping pills themselves. So that really brings us to the end. So let's just flip right back to the start and review what we hoped would be taken away from completing this module, or just reviewing with me the content of the module. Hopefully you're more aware of the age-related changes that occur with sleep. You're more aware of the potential benefits, as limited as they are, when using sleeping pills long-term, as well as the risks, whether using them short-term or long-term, and that you also feel more capable of understanding and using cognitive behavioral therapy, because you now know how to access information about cognitive behavioral therapy and know where to go to get direct access to the programs that are cognitive behavioral therapy, whether those programs are books, apps, online services, or otherwise. Before I close, I do want to acknowledge that a lot of what I have said has really been known for a long period of time. I found this quote from my grandmother's family doctor book. So she kept this on her shelf for many years. It was published in 1935. And so I thought, had I read this a long time ago, I would have been a lot further ahead than having to become updated through all of the different research that I've just gone through with you. When in bed, here's what it said. When in bed, it's best not to anticipate a bad night or think deliberately about getting off to sleep. That is cognitive therapy. The sufferer should concern himself only with making himself thoroughly comfortable and should try to stop thinking. That is a mix of cognitive therapy and sleep hygiene. A word of warning: it is most inadvisable for anyone to have recourse to sleep-producing medicines except under the personal direction of the doctor. Such drugs are dangerous when wrongly used and are seldom necessary if the natural means to sleep are fully tried. And that, again, brings out the same issues that I have spoken about, that are the concerns of the short-term or the long-term use of sleeping pills. And once again, I would like to say thank you to the Manitoba Association of Senior Centres and the Canadian Deprescribing Network for inviting me to provide this information to you. Thank you for your attention. Bye for now.